Very good morning to the respected chairpersons and all those who are present in the audience. So at the onset, I would like to apologize for the poor quality of the video images that will be shown because just like Dr. Sinha's, it was taken by a mobile phone because this is, the echo was done in a peripheral, in a rural area of the district of Hooghly a few days back. And I thought of presenting this because this was an interesting case which is not very common, if not rare. So there was no, it was done by a low-end machine, and the case that I found out was a situs inversus totalis with tetralogy of Fallot. So situs inversus is found in about 0.01% of the population, or about 1 person in 10,000. In the most common situations, situs inversus totalis involves complete transposition, that is right to left reversal of all of the viscera. The heart is not in its usual position in the left chest, but is on the right, a condition known as dextrocardia, literally the right-hearted. Tetralogy of Fallot is one of the most frequently diagnosed congenital cardiac abnormalities. The prevalence of tetralogy of Fallot is estimated to be anywhere from 0.02 to 0.04% of the population. And TOF, formerly known as stenophallot tetralogy, is a congenital heart defect characterized by the 4 specific cardiac defects, classically pulmonary stenosis, which is narrowing of the exit of the right ventricle, a ventricular septal defect, right ventricular hypertrophy, and an overriding aorta, which is where the aorta expands to allow blood from both ventricles to enter. However, its association with dextrocardia and situs inversus is reported only rarely. So this boy was just 17 years old. He had come with his father, and the reason for referring or getting the echocardiography done was his physician. He was just complaining of palpitations on and off, so his physician referred him for an echocardiography study. He's studying in the 11th standard, and I asked him that, what are your problems, what are your symptoms? He said, once in a while I feel some palpitations. I said, do you play any game? He said, yes, I play football. And because of the skin tone, it was very difficult to find whether the patient had any cyanosis also. So this was the chest X-ray. And as you can see here, dextrocardia is there and the liver on the other side. This was the ECG with sinus tachycardia and RBBB. So now, just to...
Can you go back to the ECG once?
Yeah, sure. Yes.
Can you just point towards the right-sided chest leads?
Actually, sir, this was done by the technicians there. So I had the ECG, and then I was there for the echo, and this was already done before. So I just took the pictures. Definitely the right-sided leads would have... No, the right side, because this was the normal, what they do, the technicians in the rural areas, they take the normal vector 12-lead ECG, and this was what I got. Yeah. So just to get the evidence, I'm sorry. So here, with the abdominal probe, just to find out here, the liver is seen here on the left side. Some background noises might be there. I'm sorry for that. And the anatomy, the first time when I made the patient lie down, so the anatomy was totally disrupted. It was very difficult for me, first being a, situs inversus, and then this total disrupted anatomy. So as you can see here, the ventricular septal defect very clearly, and On the right hand side, the heart is. And with the tachycardia and the difficulty in delineating, so the images are not very clear recorded from the screen itself, but few interesting things can come up. So here you can see the left ventricle on the left and the right here, and the aorta, which is because initially it was very difficult for me to, because I do it from the left hand side, so very difficult to position and find out just the opposite way in this case and then recording. So the pulmonary artery diameter it was less than 1 centimeter. And the RV hypertrophy, as you can see. On the down here, you can see the mitral valve. With the arrow. And the RV, the LV. So the similar sort of images here.
Could you access the RVOT?
Yes, sir. In this image. And this is not up to the mark recording, so.
Do you have more pictures or is it end?
No, yes, sir, this is the last one.
Because what we find is a congenital cyanotic heart disease with decreased PVF
Yeah.
and situs inversus. Now in this setup, it could be two things, either the tetralogy of Fallot or a physiology corrected transposition with
Transposition of
VSD
red
PS.
vessels, yeah.
VSD is not classical of Fallot here, though the pictures are not good.
Yeah.
It is involving the inlet as well as the other portions. So it's a very large kind of VSD, and the leaflet attachment, the AV leaflet, they are more of the endocardial cushion type. So it's not a classical fallow. I think further pictures are required to define the exact.
Yeah, actually,
pathology.
I wanted to get the case out here so that hands-on or the live demo can be done by experts like you all, but the scope was not there. So just because I had this, something which is very difficult to find out due to the disrupted anatomy, so I thought of just presenting it.
But it requires further analysis. Yes,
Yeah, sure.
Devdatta.
Sure,
I'll
sure.
just make a quick comment or question, you can
Yeah.
say. From the images that was shown, I felt there was a straddling of one of the valves. The valve on the left had a straggling with the tip attached to the septum of one of those leaflets. And the second point was that the aorta was arising more than the overriding. The aorta was arising entirely from the RV. So it would be more of a DORV with straddling of the AV valves and maybe pulmonary stenosis because we couldn't see the RVOT properly.
Yeah,
Or
that-
it could be also DORV with TGA also. We are not sure because we haven't seen the outlets properly. But as sir said, definitely not a classical TOF.
No, whatever I could see, both the AV valves are at the same level. This is an inlet VSD. You have to think of AV canal defect. Your point of DORV may not be that well. Left ventricle is very well developed. Right ventricle is not that big. It is hypertrophied. But LV was bigger. I was thinking more like that. Are we having an AV canal defect with transposition? That is what was
Yeah,
coming to my mind.
transposition of the great vessels, that could be one.
Giving a diagnosis at this kind of images should not be there commented.
it
I
is-
think let me compliment him. You're doing a great job with all these problems. I'm just slightly surprised. I mean, we are spending so much of money in a lot of things, and we can get a small pediatric echo probe there and
Yeah.
do all the things rather than. But you're doing a great job.
Yeah, and,
that's
and
what I
without
like.
any
The
symptoms at
whole
17 years.
purpose of
this
inviting Dr. Sood was just to encourage you and that you don't feel inhibited to present in a forum like this.
Right.
But then we would like to help the child. So, I mean, you can bring him to any of the institutions here in Kolkata.
Yeah, for a better analysis,
and
better
we will do
imaging.
it kind of free of charge even if so required.
Right.
Okay. So congratulations.
Still, you can in touch with you or?
No, he's in touch. I've got his address and everything.
So we would
he
like to
can-
help the young
Yeah, sure.
I think
boy.
she can do it. Ishita can do it in SS camp.
Yeah. Sure. Thank you very much.
Okay,
Thank
so
you so much.